Okay, let's dive right into this explainer on pediatric head trauma. We're going to be focusing specifically on what's known as the Golden Hour Protocol. It's all about how to rapidly identify and manage life-threatening intracranial emergencies. Because when a child's head takes a significant hit, the clock literally starts ticking immediately. How we interpret those very first signs, well, that dictates whether that child walks away safely or faces permanent, life-altering damage. So, let's get into it.
To make sense of this chaotic topic, we're breaking it down into 5 key parts today: pediatric head trauma priorities, concussions and second impacts, identifying skull fracture types, epidural versus subdural hematomas, and finally, critical pediatric red flags.
All right, Section 1, Pediatric Head Trauma Priorities. In those incredibly chaotic first moments right after an injury, making the right first move is, quite literally, a matter of life and death.
So, I want you to ask yourself this. Picture a severe head trauma. Maybe a child was in a bad motor vehicle crash or took a really terrifying fall. What is your very first clinical priority? Is it checking their pupils, trying to stop the bleeding from a nasty scalp wound, maybe getting IV access right away?
Actually, scratch all of that. The absolute crucial point here is that cervical spine stabilization always comes first. This primary shield takes priority over cleaning wounds, over seizure precautions, even over establishing IV access. And why? Because a cervical spinal injury is your greatest immediate risk. The primary brain injury already happened at the moment of impact. But if we fail to stabilize that C-spine, we risk causing a catastrophic secondary injury before we've even started our neuro exam. So protect the spine first and only then assess the airway and breathing.
Moving right along to Section 2, Concussions and Second Impacts. Let's take a minute to dismantle some incredibly dangerous myths about the most common primary head injury we see out there, the concussion. Now, this is a classic trap, and honestly, it catches people out all the time. Do you actually have to get knocked out or lose consciousness to be diagnosed with a concussion? Pop culture and sports movies certainly make it seem that way, but clinically speaking, is that actually true? No way. Here's the surprising reality. Only a tiny minority of patients, roughly 22% in some studies, ever actually lose consciousness. It's confusion and amnesia that are the true hallmarks of a concussion. If you're waiting for someone to pass out before you suspect a traumatic brain injury, you are going to miss the vast majority of real concussions. Basically, a concussion is caused by shearing forces stretching and tearing nerve fibers inside the brain, and the main treatment? Immediate rest. And because the brain is so incredibly vulnerable right after that first hit, strict return-to-play clearances is absolutely non-negotiable. If a child takes a second hit, even a relatively minor bump, before their brain has fully recovered from that initial concussion, it can trigger what's called second impact syndrome. This is a rapid, severe, and totally disproportionate swelling of the brain that can easily be fatal. The brain is just incredibly fragile during that recovery window, which is exactly why we restrict physical and cognitive activities for at least the first 24 to 48 hours.
Okay, Section 3, Identifying skull fracture types. Let's look at what actually happens when the physical force of a trauma cracks the armor protecting the brain.
So breaking down the types of fractures, linear breaks are by far the most common. They're usually simple and typically don't cross the skull's suture lines. But if the bone gets pushed inward, creating a depressed fracture of over 1 centimeter, that needs surgery. Then you have commutated fractures where the bone shatters into multiple pieces. That is a massive red flag for abuse. Finally, at the base of the skull, basilar fractures present with some really unique signs you absolutely need to know. Raccoon eyes, battle sign bruising behind the ears, or clear cerebral spinal fluid literally leaking from the nose or ears. If you see clear fluid leaking out of a kid's ear, that is a blaring warning sign.
Section 4, Epidural versus subdural hematomas. Let's see how these fractures build into the ticking clock of blood pooling inside the skull, dangerously spiking the pressure.
There is a stark, deadly contrast between these two types of bleeds. An epidural hematoma happens between the skull and the outer layer of the dura mater, and because it's almost always an arterial source, it bleeds fast under high pressure. You'll often see this incredibly deceptive lucid interval, meaning the child gets hit, seems totally fine for a bit, and then suddenly rapidly crashes. A subdural hematoma, on the other hand, is venous blood pooling between the layers of the dura mater. It's sneaky, it's a slower, insidious bleed that can creep up on you, with symptoms delayed by a full 24 to 72 hours. Seriously, do not let a brief period of the child looking totally fine after a significant hit reassure you. That lucid interval we just talked about?
That is the absolute classic hallmark of an epidural hematoma. It is a strict neurosurgical emergency. The pressure is building so fast inside that rigid, fixed-volume skull, compressing the brain, and they need immediate surgical intervention before catastrophic herniation happens.
Finally, Section 5, Critical Pediatric Red Flags. We have to cover the indicators that demand immediate, escalated medical intervention. The stakes here are just incredibly high, especially when we're dealing with tiny patients who can't exactly articulate their symptoms to us.
The PCARN decision rules dictate exactly when a CT scan is absolutely necessary to rule out severe injury. We're looking for altered mental status, signs of a basilar skull fracture, repeated forceful vomiting, or a severe mechanism of injury. But here's the kicker. Crucially, for pre-verbal infants who obviously can't tell you their head hurts, a parent simply looking at you and stating they're just not acting like themselves is a highly sensitive clinical finding. Do not dismiss it. Listen to the parents.
Beyond accidental trauma, we also must remain hyper-vigilant in recognizing abusive head trauma, often known as shaken baby syndrome. This is a mandatory reporting situation that requires immediate life-saving intervention. The clinical triad for shaken baby syndrome is just harrowing. You're looking at subdural hematomas, bilateral retinal hemorrhages, and diffuse axonal injury. Because an infant has weak neck muscles and a relatively large head, violent shaking causes the brain to violently rebound back and forth inside the skull. This triad is a massive red flag for severe abuse that causes profound, permanent neurological impairment and, sadly, quite often death. It's our absolute duty to identify these patterns instantly.
Wow. Okay, we've covered a lot of intense, high-stakes ground in this explainer today. From remembering to always protect that C-spine first, to recognizing that concussions are defined by confusion rather than just passing out, to spotting that deadly lucid interval of an epidural bleed, and of course, recognizing the silent, tragic signs of abuse. So I want to leave you with a final thought. Armed with all this, from protecting the C-spine to recognizing these subtle, critical signs, how will you use this explainer to become a life-saving advocate for your pediatric trauma patients today?